Welcome to this episode of Case Bites. My name is Ryan Gibbons. I'm an emergency medicine physician at Temple University Hospital in Philadelphia, Pennsylvania. I'm also board certified in point of care ultrasound, and I run the ultrasound curriculum at our hospital and in our med school. Today, I'm going to take you through how to utilize point of care ultrasound in your family medicine clinics. This is something that's really expanding across the world of family medicine. And in fact, there are new ACGME requirements for family medicine residencies to teach point of care ultrasound. So this is something that will continue to spread across family medicine, and most primary care offices will be utilizing this technology in the very near future, if not already. So let's dive in. So one disclosure for you, I am being compensated to do this lecture, but more than likely I would have done it anyway without any competition or compensation, but don't tell them that. All right, so let's set the stage here. You're at your office, probably not as enjoyable as this office, but nonetheless, you're at the office, and who comes in but a young lady with abdominal pain? What could be going on? It's kind of unclear. Could she be pregnant? Maybe an appendicitis, kidney stones, gallstones, pancreatitis. Honestly, it could even be a heart attack. The differential is so broad depending on her risk factors, her age, and a lot of socio or social determinants of health really affect what could be going on and what she's at risk for. So is this someone you immediately send to the emergency room and you're not able to do anything? Certainly that has consequences. She may go there, sit there for hours, have numerous costly tests, things like that. What can you do in your office to actually help expedite her diagnosis and limit some of the headaches that someone goes to their primary care and often gets sent to the emergency room for? What can we do? You're kind of limited in your outpatient settings. Some may or may not have advanced imaging like plain films. You definitely can have an EKG, and that's an easy thing to kind of give you valuable information that at the very least, this person's not experiencing an acute MI or heart attack. Blood work, probably not going to happen. It's probably something that you might be able to draw, but you're going to be sending that off to a lab, or you're sending the person to a lab place to get it drawn and then sent off. This can result in delays of days even. So there's very little in your office that you can do besides potentially an EKG. A physical exam, which I hate to say is not very reliable. So what can we do? So here's our solution. This is why we use point of care ultrasound. So it's safe and accurate. It happens at the bedside. So you're not sending this person to an outpatient imaging center. You're not sending them to the ED. You're actually doing it at the bedside. You're getting real-time clinical answers. More importantly, you're not exposing the patient to additional risk. So no radiation, no IV contrast. This is an incredibly safe diagnostic imaging modality. And you're going to make that patient happy. She's not going to have to go wait in a busy emergency room, potentially hours, costing her additional money, and waiting, for results to happen. This is something you're doing at the bedside in your office, changing care. So we kind of mentioned in the differential what some of the indications are in your office with respect to utilizing point of care ultrasound. Certainly, if she was having chest pain or you were concerned about it, like an atypical presentation, you could look at the heart. Young females, think about pregnancy. You can do a pregnancy ultrasound. Other things to think about: does she have a kidney stone? Ultrasound can find them, or at least the complications of them. You can also look for gallstones. You can look for appendicitis in certain cases if you get really good. What I'm saying is, and kind of trying to show, is that ultrasound at the bedside, at the very least, can narrow your differential, if not give you the diagnosis. So you can kind of a systematic approach to unexplained abdominal pain in your clinical office. All right. So for this young lady, my main concern was gallstones. She's a young female, pregnancy bearing age. She was having right upper quadrant pain. The gallbladder is probably going to be your prime suspect. So you're going to use your curvilinear probe. You're going to start in the middle of the abdomen, and you're going to kind of slide laterally towards the liver. And you're going to be looking for a cystic structure to identify the gallbladder. If you don't have a curvilinear probe, you could also use the phased array probe. So there's different options. You don't have to have all the bells and whistles in your office to get the job done. They can be used interchangeably. So what are the things that we're looking for when we look at the gallbladder? So first and foremost, we want to do a full examination of the gallbladder. So that involves a transverse and longitudinal or sagittal sweep, providing those views here. And you can see that on the left of the screen, and then the right of the screen here. We're sweeping through the entire cystic structure of the gallbladder. And what I'm looking at is right here. You see it's close by to the liver here, and you're actually seeing the kidney down here, diaphragms up here. Same thing over here, liver, gallbladder, and then kidney over here. The two other things that we want to think about when we're looking at the gallbladder is, what is the wall? How big is that wall? The thicker the wall, the more concerning for infection or potentially ascites, heart failure. They can cause the gallbladder wall to look thick and also have fluid around it. But if they don't have any of those conditions, if your gallbladder wall is thick and it has some fluid around it and you have gallstones, that's concerning for cholecystitis. The final thing we want to look at is the common bile duct. Is it enlarged or is it, a normal size? If it's enlarged, you're thinking something obstructive going on. I'm not going to go into the details about size, like specific sizes right now. I think it's just important that you know that you should do a full transverse and sagittal or longitudinal sweep, looking for gallstones, which will look bright white with black behind it. I will show you an example in a second. And then be sure to assess the wall and then the common bile duct to get the most information you can. So you're examining this patient. What are things that you might actually come across? So if we look porcelain gallbladder here, and what we're seeing here is just this bright white with black shadowing behind it. That bright white is a calcified gallbladder wall, and it's obscuring our view of anything else. That is highly concerning for gallbladder cancer. And if you find that, that is something that is life-changing for that patient, that you're going to be able to refer them to oncology and have them worked up and hopefully, have that removed and treated appropriately. If we move to the top, what we're much more likely to see is a gallstone, like we're seeing right there, that bright white with black shadowing, and it'll come back through again here. So the bright white shadowing, it's right in the middle of the gallbladder. Then the other thing, we're seeing a thickened wall out here and fluid around the wall. I know these are subtle probably to you, but the more you do this, the better you'll get at it. And that's consistent with cholecystitis. If the wall wasn't thick and there was no fluid around the wall, then that would just be gallstones, and you could simply treat her for gallstones. In this case, though, if this was the exam finding, she would be sent to the emergency room because of an infected gallbladder here. If you move below, this is an infected gallbladder as well, but much more concerning, where you actually have air in the gallbladder wall here. And what you're seeing is bright white air with kind of this gray shadowy artifact there. And that is very, very concerning for something we call emphysematous cholecystitis. That is a true emergency, and you should be sending that person to the emergency room. And finally, what you might see is just a really compressed gallbladder here, because that person just ate and nothing's wrong as far as her gallbladder goes, and you should be looking elsewhere. All right, so what happened with our patient here? So she ended up just having simple gallstones. She did not need to go to the emergency room. She did not need to have surgery. She just needed to be counseled on how best to deal with them. And if she did have a subsequent attack, then that would be something that we consider referring to surgery. But what we saw here was it saved her a lot of time. If you didn't have that at the bedside, your options would be to give her a strip for an outpatient imaging center. She would have to get that approved by insurance. She would have to schedule an appointment. She'd have to get there. She'd have to pay for that. We saved her all that time. Same thing if you just decided instead, hey, you should go to the emergency room. I mean, most of the time these days, there's a very long wait in the emergency department. So you're saving this patient time. You're also saving her money. You're doing a limited ultrasound at your bedside that is much less expensive than a comprehensive one done by radiology that you might refer her to. And it's much less expensive than if you would send her to the emergency department. And finally, it's safer for the patient. There's no radiation. A lot of people might just blindly say, hey, let's do a CAT scan, we'll figure it out. You actually use goal-directed care to find the diagnosis and treatment, and you avoided any unnecessary radiation that comes with CAT scans. So these are things, at your bedside, in your office that you can do that really benefits not just patient care, but so many other aspects of the patient's life that you improve by utilizing point-of-care ultrasound. Again, it's the difference maker here and in a lot of places. But we always have to be aware of our limitations, not only the limitations of point of care, but ours as well. So when we think about looking at the gallbladder and any kind of abdominal type of point of care ultrasound, big things, experience is going to be an issue. The more you do this, the experience improves. But if you're not using it routinely, your image quality suffers. Availability. Do you have this in your office? How do you get into your office? And these are things that certainly you can reach out to me. I'll provide my email at the end, but there are simple ways to introduce point of care into your office in a safe, feasible, inexpensive way. Same thing with training. You need to train on this. You need to improve your experience. And then finally, patients, their body habitus vary. So the larger the patient, they might be more challenging to image. So it's important to understand the limitations, not only in yourself, but in the technology. And if you're not getting the answers that you need, you really need to move on to the next imaging or laboratory means. All right. So the take home message, bedside ultrasound, point of care ultrasound, it is fast. It is accurate. As the name says, it happens right then and there. You are not sending this patient anywhere else. You are performing the scan, you are interpreting it, and then you are making clinical decisions based off of this technology. And finally, and probably most importantly, remember your limitations and the limitations of the patient, as well as point of care. And if you're not getting the answers that you need, go on to the next test. Thank you guys for listening. If you have any questions, please feel free to reach out to me or the Temple Ultra Squad. That's what we affectionately call ourselves as the sonographic superheroes. We have our Twitter account down there and our website. Please feel free to reach out. And I would like to take a moment to thank you for joining us on this episode of Case Bites, and we look forward to you joining us during future episodes. Thank you.